亲的各位专家、各位同道，大家好。减重与代谢外科在国外已经有70年的发展历史，而我国2000年才开始开展这项工作，其手术方式和管理与国外还有很大的差距。而我国是肥胖症的第一大国，肥胖症已严重危害国民的身体健康。为了加强国内外学术交流，推动我国减重与代谢外科的发展，我们有幸邀请到国际减重与代谢外科的诸多大咖专家，共同成立国际减重与代谢外科俱乐部，通过这个平台进行有效的学术交流。4月26号，国际与减重代谢外科俱乐部举办首场学术会议。本次会议邀请到了拉丁美洲、欧洲、中东、亚洲的多位知名专家进行学术讨论和手术技术的交流，欢迎大家出席本次会议。4月26号，我们不见不散。
Hello guys, let me introduce you to FAMIS, Academy of Minimally Invasive Surgery. So this is a FAM facility to train in minimally invasive surgery and also in bariatric surgery. So here, this is our meeting room, and let me show you also our simulator room. So here you can improve your skills in surgery. But right now, let me invite to another FAM initiative. There will be a webinar that the main goal will be to join a group of international experts to explore the theme of bariatric and metabolic surgery all over the world and in China. So this will be in the end of this month of April. That will be by webinar, and please join us.
Respectable professors and experts, and hello everyone. I'm from First Affiliated Hospital to Shandong #1 Medical Universities, and I'm from the Department of Weight Loss, Bariatric, and Metabolic Department. And now today we are here to have a webinar of the FAMIS and Bariatric and Metabolic Club, and this meeting has been initiated by Professor Hu and also Professor Almino, Ramos, and they will be the chairman for today's meeting. We have invited many experts, and I'm not going to introduce one by one in the interest of time. And now I will give the floor to Professor Hu Yanshan and Professor Zhang, Professor Wang to be the moderator. Respectful Professor Xu Chuming and Professor Tao, we are very happy to co-chair this opening ceremony. Today is a very good platform that we have simultaneous interpretation, so we can speak in Chinese for a more in-depth communication. And I also want to thank Horong Company. This is one of the companies that has contributed a lot to bariatric and metabolic activities. And so first of all, I will give a floor to Professor Hu Sanyuan, the founder of Bariatric and Metabolic Club, and he has done a lot of work for facilitating the progress in this industry. Now I'll give floor to Professor Hu. Respectful Professor Han and other experts, and good evening. Facilitated by Zhonghe Company, me and Professor Almino have initiated this meeting. We have invited professors from Spain, Italy, India, Saudi Arabia, as well as many famous and domestic professors joining us in today's meeting. On behalf of the organizer, I would like to extend sincere thanks for joining us in this meeting. As you know, bariatric and metabolic has developed very quickly domestically and overseas. However, the obesity situations in different countries are different, and each has their own features. And in order to facilitate international exchanges, we have established FAMIS Bariatric and Metabolic Club. The establishment of the club aims to facilitate cooperations between different countries. We hope with our exchanges that this can better help standardized and rapid development in this area. And finally, I would like to thank you again for joining us in the meeting. Thank you, Professor Hu Sanyuan. Thank you, Professor Hu Sanyuan and Professor Almino for establishing the club. And also congratulations on the opening of a FAMIS and Bariatric and Metabolic Club. Thank you very much for your wonderful opening speech. We are looking forward to the other initiator, Professor Almino from Brazil, to join us. And we have been friends for many years. He is a famous and expert in bariatric and metabolic areas, and he has visited us and our hospitals many times. Now I'll give floor to Professor Almino to deliver an opening speech.
Okay, that's my big pleasure to join this club. I think that we are in a very important session for today. For me here in Brazil and Latin America is too early, but I know that from the guys from Europe, this is afternoon, and for you in Asia, in China, you are starting the night of this Monday. So for me, it's a pleasure to inaugurate this session. I think that any initiative in bariatric and metabolic field, it is very important right now. We are facing difficult moments all over the world regarding our surgeries. I have been working with bariatric surgery for the last 20 years, and year after year we have been increasing our number of cases, and bariatric and metabolic surgery has becoming very consolidated all over the world with the best option for the treating of obesity and metabolic diseases. I think that starting this club will give us the chance to have more collaboration in between countries and teams. That will be very important to our work with our patients. So to have the FAMIS Bariatric and Metabolic Club will be a great field for us in order to increase our job. And I would like to take this chance to present you a very important initiative of FANG, that is the FAMIS training center in Tijuana, in Mexico. We have been working for 2 years right now in this center. That's a fantastic initiative in order to train. We have been training, I think this year, we training in this center about 40 or 50 surgeons. And we have different kind of courses. It is a great chance for the surgeons, because I think that's the only training center all over the world that you have the chance to see in a week 50 to 60 bariatric procedures. So the number of procedures is too high. The chance of working in different groups with different kind of procedures, gastric bypass, sleeve gastrectomy, revisional surgery. For the future, I'm sure that this will be the main center in the bariatric field all over the world, and I hope to receive your visit to know the center and to cooperate with us as one of the invited teachers for our courses. So my big pleasure to say that we are moving fast, and this opening of this session and to have the Bariatric and Metabolic Club in FAMIS will be also, I'm sure, a huge success. Thank you for joining us for this day, and thank you, Professor Sanyuan, for being involved with for this project, and all of you to be closer and to work together to have a better bariatric and metabolic surgery all over the world. Thank you, guys.
Thank Thank you. Thank you to professors for your wonderful opening speech. Now, I'll give floor to Professor Liu Jing'an and Professor Luo Jianfei to be the host for the next session. Professor Miguel, Francesco, Bhandari, Aayed, thank you very much for inviting me to join this meeting. In the opening speech of the two professors, they have mentioned that this platform is very meaningful for international cooperation. So next, I and together with Professor Luo will be the co-chair for the first session. First of all, I'll give the floor to Professor Luo to deliver a speech, and Professor Sanyuan to deliver the first speech. Professor Jing'an, Professor Luo, dear peers, I would like to share our experiences with you. How do we choose the surgical methods for bariatric and metabolic surgery? Our hospital is located in Qianfushan Road, and it's affiliated to the #1 medical universities in Shandong. We have thousands of beds. As you know, in China, we have many obese patients, and it's about 90 million, which ranks #1 in the world every year. And it costs a lot to perform the surgeries, and while diabetes and relevant patients have also reached 20 million. The history of bariatric and metabolic surgeries had evolved from 1970, and at that time the surgeries was not high, while in recent years we have seen 500,000 bariatric and metabolic surgeries due to laparoscopic surgery involvement, and we started to perform laparoscopic surgeries. And in the beginning, there were quite many different types of surgeries. And after decades of exploration, for example, in US and Canada, there are mainly 4 types of procedures. And first is an AGB, accounts for 54% prior to, these data is prior to 2005. And second is RYGB, accounting for 28%, and while BPD is not very high. And we also see the proportions in Asia Pacific region. Before 2005, the major procedures are AGB, accounting for 80%. After 2005, the operation methods have changed majorly. There are many complications for AGB. It may cause severe complications due to damage of gastric walls, and so less AGB. While after 2005, the major operation procedure is RYGB. The major problem with it is that the stomach is still in the abdominal cavity. So it is okay for other countries. However, for countries which has a high level of gastric cancer, this is not the proper way. So here, if you want to perform a gastric scopy, it's very difficult to find gastric lesions there. Therefore, it is still need to be decided and discussed for our IGB. It's not very appropriate for Asian countries. In 2006, and in my country, in my hospital, we started sleeve gastrectomy since that time.
And what's more, we know that the stomach can still perform some endoscopic detection. So we believe that the SG is more suitable to be used in China. But the SG in the starting time, when in 1995 and also in around 2000, people believe that this surgery was considered to be just part of the procedure, not an independent procedure, especially for the super obese people with BMI over 60. They were not so confirmed for this efficacy, and so believe that the BT. Actually people believe that the SG is not an independent one in the past. This is what people feel like about SG. But this surgery, if you want to promote it, if people want to believe it, people you have to solve 3 questions. Firstly, can SG become independent bariatric surgery? If we can take it as independent surgery, what is its effect and what is the mechanism of its weight losing and hypoglycemic effect, and how to standardize this SG? So after doing the SG, I began to do some researches, and our researchers have won 16 national natural science funds, etc. So we have several questions. First, rudimentary research. So we made a comparison between the SG and RYGB in terms of the weight loss and hypoglycemic effect in animal and models. And also, we have made a comparison between the effects of SG and SG plus, and as well as the comparison of the SG as well as other emerging procedures. So this is the result. We see that the weight loss and the glycemic effect of SG is not as good as that of RYGB, which is a golden standard, and there's no significant difference. And this is our team's research on the fundamentals and its combination with clinical researches. And we also have made a guest commentary from editorial, and this research has made sure that there's no big difference between SG and RYGB. So SG is a good choice. This is some comparison for SG versus SG plus. Yeah. And with food control, we believe that there's no significant difference between the SG and SG plus. And also, the SGs is superior to greater curvature plication and sleeve gastrectomy, and has no significant difference with duodenal surgery. So, firstly, the previous belief that SG alone is not very effective, and this is our research centers, and we have 20 patients with BMI over 50. We have made observations, and actually, And actually 22 super obese patients lost almost 34% of the extra weight after surgery. And also this is a fattest guy, and he actually lost 200 kilograms after the surgery. So that's very good. And so far, it's been 2 years, almost 3 years. His body weight remained below 100 kilograms. So that's very good. That's good news. And what is the mechanism? And aside from the weight reduction, actually the small intestine plays a vital role in improving glycolipid metabolism. And the mechanism, when this was dissected, the food will get into the small intestine very fast, and the GLP plus will increase, and the bile acid gets more, and the imbalanced intestinal flora quickly gets reflected, and the intestinal gluconeogenesis enhances, and the low-grade inflammation is elevated. So these are all results based on animal models. We found that the insulin resistance and islet function get improved, and that is why that after the surgery is done, we can we can improve the glucolipid metabolism, and thanks to the work on the small intestines. So SG is also used for super obese patients, and the conclusion is that it's not just the SG at the surgery, but we have the very strict post-op management. So the SG and a very strict post-op management is really a guarantee to maintaining the weight reduction effect. And with these researches, we have published a lot of papers, and we have published too in Annals of Surgery. So in summary here, with our fundamentary and clinical research, we have validated that the SG can become an independent surgical for reducing the sugars. And we have established the SG as our China's major procedure in treating the obesity. And actually, Mr. Zhang and Professor Lu, they have made a combination of North China and South China, and we have 95% of the bariatric surgery as the SG. And we believe that we have the mechanism research, which are the three. We can see the core function of small intestine is reviewed. The elevation-centered hypothesis was put forward, and we provide a theoretical support for SG. And we don't just do the surgery, but we also need to make sure that there's very good efficacy, which means we need to have the process management. So what kind of procedure is suitable for a patient? And I believe that the answer can only come after you have done some summary from your day-to-day work. And that is the end of my speech. Thank you very much. Mr. Liu, yes, can you hear me? Good. I finished my speech. Thank you. Thank you for inviting me to do this moderation. And I'd like to thank Mr. Liu Jiangang. And just now, Mr. Hu talk about the approaches of bariatric and metabolic surgery in China. There's high speed of increase for bariatric surgery. Mainly, it is sleeve gastrectomy and AGB. And they talk about the comparison between RYGB and the SG. So obviously, SG is really similar to RYGB in terms of the weight reduction and hypoglycemic effect. And he has also done a very good work in this aspect. So we believe that the SG has become an independent surgical solution against obesity. I'd like to thank Professor Hu Sanyuan for the speech again. Thank you very much. Next, let's invite the next speaker. Next speaker is from Spain, and Professor Miguel. His title is an overview of bariatric and metabolic surgery in Europe. And Miguel is an upper GI and bariatric surgery. He was trained in one of the most important hospitals in Spain. And he is an active member of esophageal gastric and bariatric surgery unit. He has done a lot of research, innovation, and MIS treatment of a lot of diseases. So let's give the floor to Miguel. Okay, thank you.
Thank you all. Let me share my screen. I want to thank the organization for letting me be in. Okay. Good morning, good afternoon for everyone. It's a pleasure. I am honored to participate in this event, in this webinar, and share knowledge and experience with all my colleagues around the world. Thank you. I am Miguel Angel Steiner. I am upper GI and bariatric surgeon from Madrid, Spain. The fifth global registry made in IPSO in 2019. A huge work was made to collect all the data with more than 61 countries. Give us interesting numbers. More than 800,000 operations was made, including 17 national drug registries, 25 multi-center submissions, and 19 single centers. The same registry, the fifth global registry report, taught us about the primary surgery too, and show us the difference between the chapters, the different chapters in IPSO, and the different primary surgeries made. For Roux-en-Y gastric bypass, the main the chapters who has the main number is Latin America. For one anastomosis gastric bypass, the Asia Pacific chapters has the principal as a principal operation, and for the sleeve gastrectomy, the Middle East and North Africa. Here we can see the difference between chapters, between countries, and of course between procedures. In time, if in this study made by published by Angrisani this year, we can see the evolution of the different procedures, and the main around the world is the sleeve gastrectomy with more than 50%. In the second, the Roux-en-Y gastric bypass with almost 30%, and there are slight increasing in one anastomosis gastric bypass with 6.6%, and since 2016 this study are making collecting the data of bariatric endoscopic procedures. Very interesting too. And of course, the decrease of the gastric band. If we see with more detail between different chapters, in the first graphic we can see the European chapter with the sleeve gastrectomy with more than 54%, and the second is the Roux-en-Y gastric bypass. In the second graphic, we can compare the North America chapter with almost more than 70% of gastric bypass and only 21% of Roux-en-Y gastric bypass, with no registry of one anastomosis gastric bypass. In the Asia Pacific chapter, it's interesting because there are a significant increases in one anastomosis gastric bypass, and of course the main procedure maintains the sleeves, and of course the decrease of the gastric band. And in Latin America, there are a predominance of Roux-en-Y gastric bypass with more than 55% and 30% for the sleep. Okay, let's talk about Europe and then Spain. Here you have is the same paper by Anguissani this year, the number of bariatric and metabolic procedures in Europe and of course my country, Spain. We have in Spain almost 5,000 procedures made, and here you can see in this table the difference, the important difference between countries. We all know that each country has their own particularities, but of course here in Spain we have a lot of work to do. What is the current situation of bariatric surgery here in Spain? In this study published by Arteaga y González, with more than 52 health centers with 47 public and 5 private, we have a waiting list for bariatric surgery, more than almost 5,000 patients waiting in a waiting list, with a main delay almost 400 days, and with a delay in this waiting list in more than 4.5 years. So as we can say, we have a lot of work to do by now to the future. What we are doing now to solve this, to fight in this topic. We have implemented a few years ago the fast track in bariatric surgery. We believe is the correct scope to manage the bariatric surgery. We used the opioid-free anesthesia. We think is very important. We believe it's very important. The minimal invasive surgery, almost all our primary procedures was made by minimal invasive surgery. In different countries, there are different protocols developing and carry out different studies in new surgicals, in novel surgical techniques like studies, not so new, but as sleep medicine maybe. We are incorporating the new technologies in the operating room, like 3D vision, ICG, bariatrics, or metabolic surgery, and so on. And of course, talking about staplers, we have made the change from manual, electronic, to the robotic or intelligent compression in linear stapler. And of course, there are different centers performing robotic bariatric surgery with very good results. We are talking here not only stapling. Yeah, I think is innovation, is new technologies. We have to open for this new technology, and of course we are talking about minimal invasive. We are talking about safety. We are talking about effectiveness. We are talking, of course, about the best result for our patients. Thank you very much for your attention.
Thank you, Professor Miguel, for your wonderful sharing. Professor Miguel has explained us from Spain's perspective on the progress and in bariatric surgery. He has given a very good introduction. Thank you again, Professor Miguel. And next speaker is from Italy, Dr. Francesco. Professor Francesco, you have the floor.
Good morning. Good morning.
He's going to share with us an overview from perspective of Italy.
Okay. Good morning. I want to thank all the organizer for inviting me at this great session on bariatric surgery. I thank Dr. Steiner to introduce the Europe data on bariatric surgery. I complete with the Italian data. Today, I introduce myself. I'm Francesco Caruso. I'm a general bariatric surgeon at Casa di Cura Tirrenia Hospital in Belvedere Marittimo in Italy. Today I will provide you with an overview on bariatric surgery in Italy, considering the statistic data of 2020, trend in the last 10 years, and in a nutshell, my view on which are the main areas of improvement in bariatric surgery in Italy. I would like to start my presentation with quickly describing the entity of the problem in Italy. 30% of the population is overweight and 10% is obese, with prevalence of male over female, and obesity is beginning to be a serious problem, especially in the child population. Bariatric and metabolic surgery is a good solution for treating obesity and related disease in adult selected patients, according with IFSO and CCOB guidelines, with a BMI above 40 or 35 with comorbidities. The importance acquired in Italy by bariatric surgery led to the creation of CCOB, the Italian Society of Bariatric and Metabolic Surgery, one of the most active scientific society in Italy. CCOB annually collects data regarding operation carried out in the affiliated Italian center. Very quickly, there are 3 levels of affiliation. Affiliated center, which perform at least 25 procedures each year, accredited center 50 procedures each year, and center of excellence 100 procedure each year. As additional requirement to be enrolled as accredited and excellent center, the center has to be equipped with intensive care unit. Currently, there are 133 public and private hospital centers, out of which about 58% are accredited and excellence center according to the CCOB criteria. The 93% of this center provide the CCOB their annual statistic data, which have been included in the report, which I'm going to comment. Here you can see that in Italy were performed in 2020 15,000 bariatric surgery. 2020 is a particular year due to the pandemic, COVID pandemic. So there is a little reduction in contrast with 2019. The most performed procedure is liver gastrectomy, 55%, 8,000 procedure, followed by gastric bypass and one anastomosis gastric bypass, followed by gastric bending. There is an increasing space regarding endoscopic procedure, 8% overall, and then there are all procedure that are no sleeve gastrectomy, no bypass, mini bypass. I will discuss some of this other procedure later on during the presentation. In this slide, I want to show the evolution of bariatric procedure in Italy over the past 10 years, where we can see the strong increase of sleeve gastrectomy, the decrease of gastric bending, and the great interest, especially in the recent years, in one anastomosis gastric bypass. Analyzing separately the different operation, we could see sleeve gastrectomy is the most performed operation in Italy in the context of bariatric surgery. Its popularity has grown a lot in the last 7-10 years. Probably the success of this kind of operation is related to many factors. It's a simple, relatively simple procedure. It does not alter the physiology of the gastric tract. Good performance at medium and long term. You can explore sure the stomach, and finally it could be subject to relatively simple surgical revision in case of failure. In Italy, in the recent years, one anastomosis gastric bypass acquired considerable importance, with a significant 12% of the procedure performed. The combination between restrictive malabsorption with good results in terms of weight loss and treatment of obesity-related condition, first of all diabetes control, justify its growing interest. The enormous growth of sleeve gastrectomy and mini bypass, one anastomosis gastric bypass, go hand in hand with the loss of interest in the gastric bending, which has gone from being the most performed surgery in Italy, 50% of the procedure, with a marginal role in 2020. As previously pointed out, I'm surprised about this 9%, because we know the long-term problems of this type of operation. Personally, the surgery I perform the most after sleeve and bypass is the removal of gastric bending, especially for megaesophagus, severe esophagitis, often with esophageal metaplasia, stenosis, intractable vomiting. On the other hand, the interest in gastric bypass, one of the best known bariatric operation, is the same in the year. This operation developed by Mason and Ito in 1960 remains substantially unchanged. I suppose because bypass gastric is for many surgeons the gold standard in bariatric surgery. I think that is not the most popular because there is a continuous and justified research for simple, more safety and effective procedure. In relation to this, endoscopic procedures are progressively finding more space in Italy. This includes the classic intragastric balloon and the Apollo endosleeve, which is experiencing a slow but apparently inexorable growth. Italy contributes significantly to research in the field of the bariatric surgery. I cannot explain all the news, but I want to present two, in my opinion, good work that Italian groups have been. The first, very quickly, is the on which I would like to draw your attention, is the modified sleeve gastrectomy associated with Rossetti funduplication. In this kind of intervention, I contribute to develop and describe some paper when I worked in Bergamo with Professor Olmi. In literature, there are many variants. The Nissen sleeve described by Professor Nocca, but the aim is the same, is to try to solve the problem of postoperative reflux following sleeve gastrectomy. It consists in associating an anti-reflux funduplication to the classic sleeve. Several prospective studies concerning this topic are in progress, and the preliminary results appear to be encouraging. The second procedure I want to show is the functional gastric bypass. This is a variant of gastric bypass which tries to overcome the problem on non-exploration of the residual stomach and subsequently the duodenum and biliary tract. This variant consists in placing a PTFE bending at the gastrogastric communication, 7 cm below the cardia, which mimics the gastric bypass but allows the passage of the endoscope for diagnostic and procedure. only a mention about the impact of the COVID pandemic on bariatric surgery. In the worst months for Italy, the number of intervention performed was dramatically reduced to allow hospitalization of COVID patients. Currently, strict screening protocols are applied to assess to bariatric surgery to avoid infection. Finally, speaking about the Italian perspective of bariatric surgery, I cannot fail to mention Nicola Scopinaro, recently deceased. One of the masters of bariatric surgery in the world, founder of ISTSO, founder of CCOB. Among the many innovations introduced during his great career, he has the merit to give to bariatric surgery an Italian perspective. In my opinion, a presentation about Italian perspective in bariatric surgery cannot end in other way. Many thanks to all.
Okay, just now, the Italian professor talked to us about the overview of bariatric and metabolic surgery in Europe. He talked to us about the progress and improvement of bariatric surgery in Italy. And
Yes.
he talked about OLGB and the things. So our Italian guest talked about the high proportion of OLGB, which is different from China. And also he talked about the improved procedures. And I'd like to thank Alessandro and Caruso for your great speech. Next, let's come to the next part. Okay, let's invite some guests for some discussion, including Professor Zheng Menhua from Chongqing, and also Professor Xian Ming, as well as Aayed from Saudi Arabia. Yeah,
Yes.
to do some introduction.
Yes, thank you so much for the invitation. And hello to everybody. I am it's very interesting information from different continents, from China, from Europe and other areas. But from China, I noticed also when I was reviewing the duration of stay, which was very long in China. I don't know if we can have the answer from China. There are about 3 to 4 days, the hospital stay. Is this still so, or are we going to improve in that, and how is the practice? The presentation, my question is for Dr. Hu from China. Prof. Hu.
Professor Hu, hello.
What is the hospital stay in China? Is it the same?
So the Chinese surgery is using the sleeve method, which is SGSG. And after doing the surgery, the LOS is about 3 days. So
Why 3 days? Is it government regulation? Is it insurance regulation, or what?
because we need to observe if there's any bleeding, any symptoms. And also some fat or obese patients, they may have pulmonary functions that we need to observe. So 3 days is the standard because before the surgery, people may have pulmonary or cardiology issues. Some people may even have respiratory failure, etc. So they need to spend more time.
The next question from my side for Dr. Miguel, Prof. Miguel from Spain. I noticed that your waiting time is very long, sometimes more than a year, and your private centers are only 3 or so out of. So why is that? Why the private is not taking over, and why there is no more flow of patients?
Yes, thank you. Yeah, we had a huge waiting list number of patients, and the patients depending of the health center can wait more than 4.5 years. That's is mainly because the public system we have here in Spain, the public health system, and we have some difficulties to maintain a good activity, to decrease the number of surgeries. So yes, this is a economic and political decisions, and we in our hospitals, in our health centers, we try to improve our times in OR. We try to improve our results, but we have limitations. Yes.
And why don't you have more private centers in Spain? What's the limitation of having more privatization of the centers? People open more private, people paying for their surgery and doing it faster.
That's because it's the same reason. We have a strong public system, and the people mostly choice. The choice is the public one, and not the private. And one more thing, for example, one way to try to improve this is making our surgeries with fast track. To speak minutes ago about why 3 days of staying. We have in our hospital 24 hours or hospital stay for the sleep, and 2 days for the gastric bypass. We see that it is okay for us.
Have you tried the surgery to discharge on the same day, end of the day?
No. In gastric sleeve, no, and gastric bypass, no. We tried several years ago in gastric band, but we don't do this procedure anymore since '98.
Thank you.
Okay. Professor Chen, you there? Okay. Hello, everybody.
Let's see if they will ask him.
So, Professor Jin, any question you want to ask? And we will just have to listen to three speakers. Any question for them? Okay, Professor Luo, hi, and Mr. Hu. I am Mr. Zheng and Professor Zheng. I'm very happy to join this discussion. And our center actually was set up by Mr. Zhang, and then I took over for the bariatric surgery. Actually, the work began in 2007. And you talk about the surgical or procedure approaches, and we have actually, first we started with the bending about 2007 to 10, and from 10 to 12, we began to do the bypass. And after 2012, we do sleeve. Yes, a sleeve is really good. Just like Professor Hu has said, SG is really good in terms of weight reduction and hypoglycemic effect, and its post-op management is also good, and its complication is very few. So it's not like the Anican does everything, but SG can also have some problems like the GERD patients, and SG may lead to higher GERD symptoms, and we may choose something else, like the diversion. If patients are unwilling to do diversion, we can do sleeve with plication. And also some patients, especially male patients or older patients, if they are diabetic, if they don't have a very high BMI, we will suggest diversion. And for those super obese patients, we believe that the sleeve was not so efficacious, and then we will do some other methods. And so the SG is really acceptable to patients, and the patients love it. So it's okay. We have a main issue here at our center. That is, Though we started the bariatric surgery in 2007, but we grew very slowly. The patient's number is very low. It's it's a big issue. It's hard to just focus our energy on the bariatric surgery, and patient recruitment was also challenging aside from other issues. So I want to ask Professor Zheng. Just now, you talk about the weight reduction of bariatric surgery conditions very good. We want to listen to Mr. Xieming, Professor Xieming. Yeah, Professor Xieming. Hi. Can you talk to us about your center? Any question that we can answer? Right? Any question? Yeah. Just tell us about your center. Thank you. Thank you, Mr. Hu, for this whole platform, and also thank the moderator for introducing me. Actually, we begin the bariatric surgery. It began in 2016. So from 16, we had 3 cases. We are a comprehensive hospital. We are and we are in the esophageal or GI specialist department, and we have conducted almost 20 bariatric surgeries this year. So we have improved the number so far. So we use sleep for the bariatric surgery, and for I feel that we like to choose the verified, easy to manage procedures. So I want to ask the 2 foreign guests, Miguel and Alessandro, 2 professors, for those bariatric surgeries. In terms of the time for the patients, what is your patient cost for the SG? Yeah. So Miguel, can you answer the question about how much money each patient has to pay for the SG? And also Professor Francesco.
In Italy, nothing.
Yes, in Spain, in the public system, nothing, of course. And in a private setting, for a sleeve gastrectomy, a patient can pay, I don't know, 10,000 or 12,000 euros for a sleeve gastrectomy.
So Europe has a very good insurance system. So the cost can be very easy, right? Not the case in China. So you heard the answer, right, Professor Xie? She's very glad to hear it. Yeah, good. Thank you. So any question from anything you want to share? Yeah, that's all for me want to say. And just now, we have invited Professor Hu Sanyuan and 2 professors from Italy, from Spain, and they will talk about the bariatric surgery in each cities, in each countries. And also we have listened to Professor Zheng and Professor Xie, and also Professor Aayed AlQahtani. Thank you for everything. And we mainly talk about the choice of bariatric surgery. And in this section, we're very happy in our discussion, and we're very informative in our speech. This is the end of this part. And now let's come to the discussion part. Next part. Now give the floor to Professor Zhong Weimei. Okay, thank you. Thank you for the moderation and Q&A session. The 3 experts from China and from Europe have offered their perspectives on everything. And so let's come to the second part of keynote speech. Okay, let's welcome Professor Zhu Jiangfan and Professor Ji Gang to preside over the second half of the keynote speech part. Let's welcome them. Okay, in section we have 3 keynote speakers. The first one is Aayed from Saudi Arabia, and we have Professor Bhandari from India, and also we have Professor Almino Ramos from Spain. And they are going to talk about their own topic, and the bariatric surgery in Middle East, in India, in Latin America. Okay. Firstly, let's welcome Aayed AlQahtani from Saudi Arabia.
Thank you so much. Thanks for the invitation. A pleasure to be with you today and to share with you our experience in Middle East overview. Did you see the slide? You see it now?
Yes.
Okay. We'll put it in the mode. Let us see the. Okay. So we'll be talking today about experience in the Middle East. We know obesity by itself is really growing, and there are some statistics showing almost 30% more than the prevalence of obesity, 30% more than its prevalence in other countries in the region compared to maybe Asia or other part of Asia, but in the Gulf states, the prevalence is very high. And there are some projections that in 2022, maybe reaching up to 70% as obesity, not only obesity and overweight, but obesity will be more than 30. In kids, again, it's very significantly growing, and we expect at least in Saudi Arabia we'll have 2 million kids are obese. There are some studies in schools for kids and showed almost quarter of these, or up to 30% are obese, meaning BMI percentile more than 95 or corresponding to BMI more than 30. For that reason, there are a lot of strategies in the region. One of them, establishing some professional societies, campaign, programs from MOH, Ministry of Health, to combat obesity. Saudi FDA has implemented some sugary tax and energy drinks and soft drink tax. Calories are mandatory now to be clear and positioned on restaurant and all food services. Ban of junk food in schools, canteens. School-based awareness campaign. And then training for professional and national-wide awareness about obesity. So there are a lot of work to work against this disease. Additionally, in the region, Gulf State, there are many societies, many meetings are talking about the topics, establishing some guidelines, establishing some scope of services and scope of fighting this epidemic. Insurance recently included bariatric surgery, mainly and only sleeve gastrectomy, and only for those with BMI more than 45. For some reason or another, they only included one procedure and included BMI more than 45. We hope this will change, but at least it's a start. You can see worldwide, as we know, sleeve gastrectomy is prevailing, more than 60–70%. Band is going out of the picture. Bypass is decreasing. We have other, as we know, many bypass and other coming in the picture. And we have revision surgery is coming and more appearing. In our practice in the region, we know the most commonly performed procedure is sleeve, followed by mini bypass, followed by Raw and Y. And this is from our friend Ashraf Haddad and colleagues from the region. There are many studies about different techniques, different ways of dealing with the disease, and mainly we are talking about sleeve and mini bypass and bypass. So there are a lot of work has been done. If some people were reinforced, like in this study, and maybe better hemostasis or so on, reinforcement, but there is no difference in leak. Some people also increasing the size of resected, looking for leaving more antrum or less antrum. This is our friend Ahmed Abdullah has published this paper to say, and there are other papers in the literature. Some people will say if you leave more, and honestly, that's our practice and our experience with our patient. If we leave more antrum, the weight regain will be more on those with big antrum. Whether to inject the pylorus or no, again, another study. So there are modifications in different type of techniques dealing with complication like any other countries and like any other regions. In our practice, in our center, we are not different, but we added more other procedure. Like we know sleeve is the commonest, mini bypass second, raw and white hair as surgical techniques. Revision is very frequent in our practice. Almost there is no list without 1 or 2 revision. And then we go for endobariatric. We have significant endobariatric experience in our center. If you look to sleeve long-term up to 10 years, we have performed up to 11,000 cases, and at 10 years follow-up, we reached to some numbers with good outcome reaching 60% excess weight loss. Comorbidity resolution as 10 years still maintaining up to 60% in these cases. In Lebanon, we have comparing between bypass and sleeve, excess weight loss as 5 years in sleeve 72 and bypass 63% from the group in Bassem Savadi and his group in Lebanon. From Qatar, we have similar result at 5 years for sleeve in adolescent group and adult group will not be different. Also, Kuwait at 5 years, 60% excess weight loss. In Egypt, from Dr. Osama Taha and his group has published 1,500 cases of mini bypass with very good weight loss. As we know, mini bypass, more weight loss, 80% excess weight loss, but most importantly, as we know, the comorbidity resolution, 84% in diabetes resolution at 1 year. Also from Lebanon, mini bypass, similar, almost 72% excess weight loss in 1,000 cases. We have this experience also from single bypass for resolution of type 2 diabetes, similar to Dr. Taha experience from Egypt, where you see 91% complete remission of type 2 diabetes, partial remission is almost 3%. Diabetes remission also repeatable results from different centers in the region. And single bypass, which is very interesting study to see should we tailor it to the total length of the bowel for mini bypass or single anastomosis bypass. Should we tailor it to the total length or should we only fix it to 200? So it seems to be if you tailor it, you'll have more, as you can see, the study tailored bypass has significant higher excess weight loss and total weight loss at 12 months. But the comorbidity improvement is the same. From Saudi Arabia, there is a small study about mini bypass, which again, similar results, 80% excess weight loss. United Arab Emirates compare Dr. Tariq Mahdi, compare 3 procedure, which is newly introduced procedure, you can see in the region and worldwide, SASI, compared to single anastomosis bypass and sleeve, and it seems to be greater weight loss and excess weight loss after SASI compared to single anastomosis and sleeve. However, higher long-term complication with SASI, which is obvious. Conversion to another procedure. This study from Cleveland Clinic, Abu Dhabi, Matt Crow and his colleague, 46% convert to bypass because of reflux. we know it's a problem, reflux and sleep, and we know the solution. Enhanced recovery, which is very important, and I'm interested also to see that also in Spain and others, and I think ERAS should be implemented, the surgery should be implemented, so this is also in our region, from Guido Manard, where he is doing the enhanced recovery in his cases and has approved the hospital stay. And this is his protocol that has published. In our practice, we have done also day surgery in 777 cases, and we discharge same day, and the hospitalization is almost less than 3%, unplanned hospitalization. Some of them because of fever, some of them because of low oxygen saturation, but no major reason for hospitalization. But it's very visible, and this is done, as we know, in Canada, in US, in multiple centers. Endobariatric is very common in our practice. We have done till now 3,000 endoscopic gastroplasty over stitch technique, and the result is promising, where up to 3 years we can see 60, almost 57% excess weight loss, 14%. And we compare it to it is not replacement for sleep, and it is only for those who are not yet candidate for sleep gastrectomy, or they are completely rejecting bariatric surgery. Still, there is significant difference in weight after 3 years or 2 years, but it is a good bridge and good solution for those who are not yet candidate. We have done it in pediatric, and we published this up to a year and a half, and I think it's very interesting topic for pediatric bariatric surgery. Weight loss in pediatric is a reversible procedure. Can be repeated, can be removed. You can do sleep after that. There is no limitation for this procedure, endoscopic gastroplasty. So it's very, I think, suitable for kids. Adverse event is very minor, less than 2.2% overall, and most of them are not major complications. Reem Sharia from US has published 5 years in the ESG, endoscopic sleep gastroplasty, and seems to be maintaining good weight loss up to 15% total weight loss. Can we do it for revisional surgery as post-sleep or post-bypass? It is. We published our study with our colleagues from Mayo Clinic and other group, and we showed, yes, it can result in very good 10% total weight loss at 1 year. If you compare, this is from EFSO registry, and interesting comparative things that we try to put it in this presentation from China and Middle East. We can see the median BMI is less in China compared to Middle East, 45. In age, they are similar. In diabetes, we can see they are similar, 30% diabetic in China and US. And United Arab Emirates as representative of the region. 15% to undergo bariatric surgery. We're having hypertension in China, but hypertension in our region is more, 40%. So more hypertension in the group in our region. And sleep apnea is not much different, maybe more in China. And majority of the operation in China and in our region is all sleep, up to 80%. This is from EFSO registry. How representative it is, maybe it's very representative, but at least this is the statistic available. This is very interesting. Post-op stay is very long in China. In our region, still long, 2 to 3% days, and it should be less than 24 hours or 24 hours. In our practice, they are discharged the next day. And as I said, we have done also day case. Conclusion: high obesity prevalence rate promote policy and procedures in the region. Several bariatric procedures are conducted in our area, and the most commonly performed procedure is sleeve, followed by mini bypass or single anastomosis bypass and Rowan. New trend toward enhanced recovery and day surgery are prevailing now or coming in the picture. Revisional bariatric surgery is coming more and became more apparent, and because most likely the performing procedure that will require revision, like sleeve and others, or prevalence of the surgery itself. endoscopic bariatric therapies is really growing fast, and it's very interesting to have it. And I think as bariatric surgeons should be available in our clinic and our support for our patients. Thank you.
I'd like to thank our friend from Saudi Arabia, Professor Aayed. Thank you very much. And that you speak very fast, so yeah, we can get into more discussion in the Q&A session. Okay, next, let's welcome Professor Bhandari from India, and we cannot hear you.
Hello, can you hear me now?
I mean, we cannot hear the Chinese person, not you. Oh.
Hello?
Can you hear me?
Yes, I can hear you. Can I start my presentation now?
They're talking.
Should I start my presentation?
Yes, you can begin. Yes, you can begin. Please.
Okay.
Yes.
Thank you very much, Feng Surgical, for inviting me to this Bariatric and Metabolic Club alongside Professor Almino. These are my disclosures. I work in this institute and serve as a chair at the Medical University. I am a consultant to all these companies and work with Professor Phoebe. We have done more than 15,000 bariatric procedures here at Indore. I'm going to discuss about the bariatric surgery present and future. And Dr. Phoebe has taught us that paradigm-changing ideas are usually met with derision. Whereas obesity is an epidemic of weight regain, it has worsened and newer techniques have come. But if we go into the history of bariatric surgery, we realize that non-surgical methods have not worked. And therefore, we have bariatric surgery. And at this point of time, surgical intervention in obesity is the most powerful treatment for the treatment of morbid obesity. And the least effective current surgical operation is many-fold more effective than any known non-surgical treatment. Bariatric surgery started in 1954 as an investigational procedure. And now we have evolved where we have less than 1% mortality. Bariatric metabolic surgery has evolved from open laparotomy to robotic and single incision surgery. These are the known mechanisms for bariatric surgery, as all of us know. And we also appreciate the role of the gut hormones. But if we see way back in 1981, the body weight was controlled by lower gut hormones was the theory. And this theory was further strengthened by the fact that ghrelin was one of those hormones which was removed through sleeve gastrectomy, which said that gut plays a critical role in metabolism and bariatric operations alter the anatomy of the gut. This also gave rise to the concept of diabetes surgery. And see this article way back in 1983, which says that gastric bypass treats type 2 diabetes. 12 years later, Walter Pori said, but he got that credit that he said that metabolic surgery works by weight independent mechanisms. And these are so many randomized control trials which prove that type 2 diabetes can be treated after bariatric metabolic operations. So bariatric metabolic surgery is not only done for the weight loss now, but the Diabetes Surgery Summit said that patients of Asian origin with BMI less than 27.5 can be treated by bariatric metabolic surgery. These are the three main operations done across the world with gastric bypass and sleeve, but the sleeve is currently the most commonly performed operation across the world. There can be several reasons for the popularity of sleeve, but these are the known mechanisms for the functioning of the bariatric metabolic surgery. Based on the better understanding, there should be an armamentarium of procedure which the surgeon should perform, and that's why we need standardization of bariatric and metabolic procedures. This standardization of bariatric and metabolic procedures and an algorithm whereupon we do not do just one procedure, but we use all different procedures in bariatric and metabolic surgery to treat obesity and type 2 diabetes. The robotic surgery is the future of the bariatric surgery. We have the robotic-based platforms, and these surgeries are coming to the scarless robotic surgery, where you have a single incision robotic-based platform, whereupon these surgeries can be performed through robotics by single incision. The digitalization of robotic surgery and surgery platforms coming by different other corporates would be the future of bariatric surgery, as we can predict. Also, we know that the weight regain is one of the major problems with bariatric surgery. So the future may lie in banding these procedures. Although if you talk, most surgeons across the world have stopped banding, but we are seeing the research of a band to put a ring around the bariatric surgery to prevent the weight regain. And this is not new. We see the banded sleeve data not only coming from India, but from across the world, where they say that there would be 15 to 60% non-responders. And imagine with the way we do bariatric surgery, if we have 60% of non-responders, we will have weight regain. This is a photograph showing the dilatation of the outlet, and therefore the future lies, whereupon if we do not band these pouch, you see in this article, there is as high as almost 60% of the weight regain because of dilatation of the small bowel and the patient eating into the rumen. So I think the future of bariatric surgery lies in the banding of these procedures by these mechanisms. We know that the theory goes way to John Leaner, which said, if you apply a band across the pouch, we see that the weight regain is less in the future. This is our own data, which shows that, confirms the hypothesis by Fisher, which shows that long-term results suggest that a Cialis ring around the stomach prevents the weight regain. Another paper, another systematic review, which says that banded procedures have almost similar weight loss to biliopancreatic diversion without much complications. So I'm not going to go into the details of the systematic review, but what I would say that the banding of these pouch in these operations would be the future in the bariatric surgery for better weight loss maintenance and for good weight loss outcomes. At the same time, we see that these procedures are now being done on the mini gastric bypass and also being done on the banded sleeves. So the data, not only from our center, but from other centers is coming. And these are the slides which show that even for the revision surgeries, the banded procedures would be preferred. And a lot of surgeons are doing the banded procedures to prevent the weight regain. This is a photograph where we see that this band is not like the adjustable gastric band, but lies very loose around the pouch, and it prevents the weight regain in the future. Having said that, there are complications like band erosions, which can be easily managed by endoscopy, as you can see. Also, the next future of bariatric surgery is something which is called as the non-surgical weight loss method. So we are talking about the endoscopic sleeves. We saw Professor AlQahtani, who did a largest series of 3,000 cases, and we see that the future is how we bridge this gap between bariatric surgery and pharmacotherapy. So the endoscopic interventions, we are seeing a lot of medications coming up on the horizon, but there has to be a gap between these two, and the endoscopy is fulfilling this particular gap. We are seeing that in orthopedics, cardiology, we have arthroscopy and angioplasty between a cabbage and an exercise and a diet. Similarly, an endoscopy between the exercise and the sleeve or RYGP is the future of bariatric surgery, whether we believe it or not. But 10 years down the lane, we are going to see a lot of these interventions in the bowel, including the magnetic anastomosis and also a lot of other things. So bariatric endoscopy, along with the banded procedures, looks like the future of bariatric surgery. I'm not going to go into the details of this because this is a 10 minutes of a presentation. I just want to take you through the data from our center. This is the Asia's largest series published. For the endoscopic treatment, are they effective? Are they safe? Do they last? Do they need? Are they reversible? Are they upgradable? So yes, they are effective. Yes, they are safe. Yes, they last, but not as long as the surgery. Yes, it would depend upon how much durability are we expecting. Some of them are really reversible, like the bands and endoscopic sleeves. And yes, they are very easily upgradable operations. We also see that the revisions in bariatric surgery have got a lot of morbidity, and therefore endoscopic revisions are the future. So what conclusion I draw? I would say that we should stop the blame game. The endoscopists, the surgeons, and the endocrinologists are the three set of the wheels should stay together. The endocrinologists have started to accept the diabetic surgical interventions, and therefore we should cooperate with them. The insurance coverage has to be the future, and all the countries which are the IFSO members should have almost 100% insurance coverage for future metabolic operations. And we will see the increasing role of incretin analogs like GLP-1s, PYYs, GIPs in our practice. At the same time, the development and evaluation of criteria for surgery to treat patients without considering BMI as a criteria for type 2 diabetes should be the future endeavor of all bariatric surgeons on this panel. We need to investigate the long-term effects of surgery on microvascular disease. This is something where we have very less number of publications, including the critical vessel disease, and we need a high quality disease in this area in the future. We need to refine the structure of therapeutic algorithms to incorporate metabolic surgery in our practice, and we need to establish national and international registries of metabolic surgery who are being treated for type 2 diabetes, specially designed to facilitate standardization. We should identify optimal definitions of outcomes to be used across the treatment modalities, increasing understanding of surgical mechanisms as to how these are effective in the newer alternative therapies, investigate the role of device-based GI interventions to treat type 2 diabetes, just like endobarrier and several others in the loop, and investigate cost effectiveness of specific procedures in the use of surgery in the treatment of distinct clinical scenarios. So thank you very much, ladies and gentlemen. It was a very elaborate, it was a very wide topic I had to cover in 10 minutes, but this was what I conclude. Thank you.
Yes, thank you, Bhandari. Within a short time, you offered a lot of information, and thank you very much. And your slides kind of flash by, and that's fast, and that's not easy, right? You have performed 15,000 bariatric surgery, just amazing. And I believe that in India, there are a lot of fat people, obese people actually, and actually I have done just 1,000, and I'm just less than 10% of what Bhandari has done. So yeah, next speaker is from Spain, who is Almino, and he is he used to be president of IFSO, and I wish to say he is the main he is part of our main sponsor for this whole conference, and he's gonna talk about the overview of bariatric surgery and metabolic surgery in Latin America. Let's give the floor to Almino.
Okay, thank you again. That's my pleasure to join in this block with the presentations of Professor Aayed AlQahtani and Professor Mohit Bhandari, both with great experience in bariatric and metabolic surgery in India and Middle East. And my job is to present to you the situation of bariatric and metabolic surgery in Latin America. So in Latin America, we have right now 17 countries with bariatric and metabolic societies registered in IFSO. So we have Argentina, Bolivia, Brazil, Chile, Colombia, Costa Rica, Dominican Republic, Ecuador, El Salvador, Guatemala, Honduras, Mexico, Panama, Paraguay, Peru, Uruguay, and Venezuela. So we are looking for a region that corresponds to 12% of world area with a population of 600 million people here. So here you can see the countries, the places. And also in this chart from world obesity, you can see that in Latin America, we have different levels of obesity, but in general, we have a lot of obesity in the different countries. We have some countries with more than 30% obesity. And this is another chart you can see that we have in Mexico more obesity than we have in the United States. And also here we can highlight other countries from Latin America with a very high number of obesity. That is Venezuela, Argentina, Chile, Peru, and Brazil. So look to the numbers and you see that really we have an increasing rate of obesity and metabolic disease in our countries here. I will use also this study that Professor Miguel showed us here. That is our last register in IFSO. That is traditional published every 2 years. So this study corresponds to the year of 2018. And we have here Luigi Angrisani, Antonella, Paola, myself, Scott Chicora, and Lilian Cow as authors of this study. So when we look for worldwide numbers of bariatric and metabolic procedures, you can see that we are very close to 700,000 procedures all over the world. We have every year we have some increase in this number. And when we compare this with the numbers from Latin America, Latin will correspond to about 25% of all bariatric and metabolic surgery done all over the world. So here you can see that we have North American chapter with 32% of worldwide bariatric and metabolic procedures, European chapter with 27, and third we have Latin America with 25, Asia Pacific chapter with 10%, and Middle East North Africa chapter of IFSO with 6%. So this is the distribution we have about numbers of procedures in the different 5 chapters of IFSO. Again, if we look for the total number, you can see that we continue to have an ascending number in sleeve gastrectomy. Roux-en-Y gastric bypass that was decreasing tends now to be flat with around 30% of all worldwide bariatric surgery. We have an increasing numbers of one anastomosis gastric bypass. Bends definitely have been abandoned, and it's interesting to see that we have an increasing of endoscopic procedures, as we have been shown here by Professor AlQahtani and Professor Mohit Bhandari, showing the role of endoscopic treatment in the future of the management of obesity. So when we compare this with our Latin American numbers, you see that we have great differences when we compare the total with the numbers in Latin America. So here in Latin America, and we are trying to understand better these numbers, we don't know if Latin American bariatric surgery is more conservative, but you can see that this is the only chapter that we continue to have Roux-en-Y gastric bypass with more than a half of our bariatric surgeons, 55% of our surgeons. Sleeve gastrectomy is the second with 33. So you can see that we have a different situation in comparison with the world. And one anastomosis gastric bypass is increasing over time, but much less than when we compare with worldwide numbers. And also endoscopic bariatric procedures are becoming very important in Latin America. As you can see, we are close to 8% of total bariatric procedures in the endoscopic field. So in a summary of these numbers, we can have the three main procedures worldwide. In Latin America, sleeve gastrectomy corresponds to 33% of the procedures. Worldwide is 55. Roux-en-Y gastric bypass correspond to 55 in Latin America, worldwide is 29, and one anastomosis gastric bypass corresponds to 6.5 worldwide and 2.5 in Latin America. So this kind of report are based in society presentation of the data. But we have another IFSO registry that is based in hospitals or surgeons presentation of the data. So they are a little different that we presented the last version in 2019 in the Congress of Madrid. And here also we can see by the kind of procedure. The first one in green is Ruxanide gastric bypass, and you can see here that Latin America is the main region for Ruxanide gastric bypass. And when we talk about one anastomosis gastric bypass, you can see that the main region here is Asia Pacific. Actually, Latin America is the region with few numbers in one anastomosis gastric bypass. And when we go to sleeve gastrectomy, MENAC, Middle East, North Africa is the region with major numbers. And here in Latin, we have a situation that is the region with less numbers of procedures in terms of sleeve gastrectomy. We have MENAC, we have North America, Asia Pacific, Europe, and in the last, in terms of recommendation of sleeve gastrectomy, we have Latin. So this is a chart with a summary in the situation in the different countries. Here in Latin America, you can have in the second column, you have the numbers of procedures, and here is pretty clear that Brazil is the country with the major numbers in Latin America. We have, after Brazil, we have Colombia, we have Mexico, we have Argentina with big numbers, we have Chile. And when we look for the basic in bariatric in these countries, you can see that in the majority of the countries we have national guidelines regarding bariatric and metabolic surgery. In majority of the countries, obesity is treated and considered as a disease, and we have different situations regarding reimbursement. I think that the best country in terms of reimbursement for bariatric surgery, it is Brazil, where here we have a public and private reimbursement for bariatric surgery. This is a law in the country, and this is, I think, the main reason that the big numbers that we have in Brazil. Also, I think that is important to say that in this time of coronavirus affecting our countries, we have a big decrease in the number of cases in all of the countries in Latin, but we are slowly recovering the numbers. I think that the situation is improving month by month, and we project that by October or November, we will have a best situation again, recovering the numbers of the previous years. So that's the situation in Latin. I thank you for your attention for our presentation. And again, it is my pleasure to be sharing with you the foundation of FAMIS Bariatric and Metabolic Club in this meeting. That will be a great chance to increase our international cooperation in bariatric and metabolic surgery. Thank you again.
Thank you very much for sharing. I have chosen a wrong channel to English, so perhaps some professors haven't heard me in China. What I want to say is that I'm very happy to get involved in this seminar. Within 1 hour, I get to know the progress of bariatric and metabolic surgeries in all countries. This is very good platform. Now we have a next session. We have Professor Zhang Zhen from number 1 affiliated hospital in Anhui, and also Professor Miguel to join us in the next session for discussion. Now I have 2 questions. The first question is goes to Professor Aayed from Saudi Arabia. I have done 200 surgeries, but we are also conducting interactions between brain and intestinal tract, and we found that the brain functions changes before and after the surgery. And we have seen some changes. So we designed a program. We developed a helmet to have an internal or external adjustment. We used an infrared externally for adjustment. So after 3 to 4 ranges of treatment, it will reduce the patients by in their weight. So do you have any studies regarding brain inference? Though I'm a surgeon, but I think surgery is not the optimal or the best solution. We may not understand the mechanism of an intestinal tract or gastric tract very well. We may have some other mechanisms to stimulate weight loss. So do you have any studies in brain or digestive tract? And second question for Professor from India, Bhandari. Are you still performing surgeries since the pandemic is so severe in India? Last year, when China had a very severe COVID-19, almost all surgeries were stopped. So what about India now? Do you have good preventions against COVID-19 in surgery? So these are 2 questions.
For me, thank you so much for the question regarding the study in the brain changes and others. Definitely, this has been studied not only from us, but others. For us, we have studied what is called wanting and liking after bariatric surgery, especially sleep. The change, and we see it in our practice, that when you see a person who has done a sleep gastrectomy, the signaling to their brain, to hippocampus and the centers for food preference, wanting and liking change significantly. You will find somebody who will say he was really preferring chocolate and afterwards he will hate it, and so on and so forth. We have done this study and we have published it and saying, yes, sleep gastrectomy changed the signals to the brain. Now, mostly these signals come from the GI tract, whether through hormonal or neuronal mechanism like ghrelins and other signalings. So this is definitely, there are a lot of studies, as we know, in ghrelins and others and peptides, and this study also in the brain, and then another study on functional MRI after doing surgery. They study their brain, and the activities in their brain after bariatric surgery change significantly as well.
Okay, so as far as your question is concerned, yes, we are having a very bad situation here in India now. We were good in the month of March, and I did around 110 procedures in the month of March. And this month of April in India is very bad. We have problems with, as you can read in the media, we have problems with lack of supply of oxygen and lack of ventilators, lack of drugs like remdesivir and tocilizumab all across the country, and we have young people being affected. So I stopped doing elective bariatric procedures from 10th of April. So it's 15 days I have not done elective bariatric procedures. But as you know that in India, at Indore, at my center, because of Dr. Phoebe and myself, we are a reference center for a lot of these bariatric complications from all across the world, I would say, and Asia Pacific. So we receive a lot of patients with sleeve leaks, gastric bypass complications like strictures and stenosis. So we are preying upon patients with complications. We did some complications of leaks and bypasses and some endoscopies and these sort of cases, but no planned elective bariatric procedures, because I think this is a time in our country where we need to optimize our health resources towards patients who are in dire need of oxygen. We have young deaths here, and as you can see in my hospital, I'm associated. I'm a vice chair to a very large medical school here in India. That medical school, which is owned by my family, has 1,500 beds dedicated to a COVID facility, and I run that medical school with my family. And so at this point of time, I would say 80% of my time since 10th of April is in treating very, very seriously ill patients. I'm just doing bariatric emergencies like leaks, gastric bypass, strictures and stenosis. That's all. Once the situation improves, we are expecting in the month of June, we will shift to full swing in bariatric surgery.
Have the full support, Mohit, for you and your country from all of us.
Thank you so much. Thank you so much. Thank you so much.
So here in Brazil, we are not in a good situation also. And let me ask you, Mohit and AlQahtani, what is your screening process right now for doing bariatric surgery in your countries? This is based just in PCR, or are you using CT also?
Okay, so Dr. AlQahtani, you can answer, then probably I can answer.
Sure. I think you are in a major trouble, Mohit, to answer.
Okay.
For us, being not prevalent, with the maximum recorded cases till now is less than 1,000 a day, 1,000 case, and the critical cases is 1,000 throughout the country, those who are requiring ICU admission. So the best scenario, which is if you want to be safe, it's not a national standard, but some surgeon mandate to use it, some hospital mandate to use only PCR. Some other do it on only screening, clinical screening. Any contact, any symptoms, any previous admission, any travel, any so. If nothing, so that patient will go for surgery without PCR. So the two options, either clinical only or PCR based, and it is left for the hospital and the surgeon discretion.
Okay, so as far as we are concerned, Almino, we have to, as Professor AlQahtani said, we have 400,000 active cases in India now. It's rampant. So we do as the patient gets inside the hospital, we first, before even calling that patient, we take a very detailed history about any contact, any fever, sore throat, or anybody in the family who had a history of COVID-19 infection. And once we rule out all these things, we call the patient. The patient is not admitted directly. The first test we do is an antigen test along with a CT scan. There is a facility outside our hospital, our bariatric center, which keeps the suspected COVID positive patients. So there these patients are kept in isolation. Once we get an antigen negative, we bring these patients inside our bariatric center, and then they are exposed to a chest CT scan and a PCR test. And once we see that the PCR is negative and there are no findings on the chest CT, only then these patients are admitted for bariatric surgery. If we have a PCR which is negative, but there are significant findings of more than 15% involvement of the chest CT or CORAD score more than 5, we are not doing bariatric surgery on these patients, but shifting them to a COVID care facility. Also, post-operatively, when we discharge the patients, we again do a PCR test and we ask them to quarantine at their home for 15 days after the bariatric surgery. Just 2 days back, one of my patients I operated, I think 10-12 days before, had COVID-19 infection, landed up at my hospital with diabetic ketoacidosis. So I'm being more cautious now. I think situation is not good here to operate. I don't think I should be doing elective bariatric procedures for another month or so. I don't know, maybe 2 months. Our country is in a bad shape at this point of time.
Thank you very much. Thank you, the three of you. I believe that the issue is a severe one in a lot of countries, and I hope it's the best. And also, according to the China's experience, I believe that the surgeons, when it was COVID-19 peak, we didn't perform a surgery for 3 or 4 months because that is a good protection of everybody. Then thank you for your sharing, and I'd like to wish you that other countries can conquer COVID-19 and become COVID-free. And we pray for you. We hope for the best for you. And we still have 2 interactive guests, and who is Professor Zhang Zheng. You there? Yes, I'm here. Yes, I'm here. It's 3 professors. Yeah. Anything you want to say about the 3 professors? I don't have any advice. I believe that the 3 of them, in their own locality, offer a very practical advice on how to, how to proceed with the care and how to do the surgery or not do the surgery. And I feel, the cost of bariatric surgery is not so high, and actually, our center, though is a latecomer to the bariatric surgery, and after we return to China in 2017, began to do some bariatric surgery, but not so many of them in my center. I want to ask questions for 3 professors. So one question for 3 professors, right? I think one question for each of the professors. We have to be strict with time. Okay. And I want to ask Aayed, I want to ask a question. And so these patients who are willing to do the bariatric surgery, these patients, it's hard to persuade them to do it sometimes. And we're not so sure if patients are willing, right? How do you do persuasion for the patients? How do you, first question for Aayed. And the second question is for Bhandari. And you do have a lot of, surgeries. And because you see a lot of patients who regain weight, how did you choose your methods of your procedure? And the third question is for Almino, because if you look at Latin America, I'm not so sure what are the reasons that they have more gastric bypass than SG in Latin America. So all of you, Aayed firstly, I guess.
अरे वो जो हाँ एक्सरसाइज वाली ओपन कर देना, उनको अंदर आने देना.
Yeah, any of you guys, please ask a question. Actually, Professor Zhang asked a question for each and every one of you. And I think why, especially Almino, why did you have more bypass than SG?
Yes, that's an interesting question, and we are trying to look for the answer for this question. And maybe one of the reasons are related that we have in our countries a long story regarding bariatric and metabolic surgery. So, for instance, in Brazil, we have started with bariatric surgeries in the 70s. So that's a long story, trying different procedures. And also, I think the experience with the bands are not so good, and based in the experience of the surgeons in the bands, they are a little afraid about moving to sleeve gastrectomy. That's the reason. So surgeons here are more conservative, and I think they are trying to look for the results of the sleeve and base it on that, moving little by little.
Okay, thank you very much, Almino, for the share. And the other two professors, if you're ready, maybe let's listen to what Miguel has to say. Yeah.
So I was asked about how do I choose my revision procedures. So, we do a lot of these revisions, and the most common procedure we revise is a sleeve gastrectomy. As all of you know, that's the most commonly performed procedure across the world. We convert most of our sleeves into a banded gastric bypass with a long BP limb of around 150 centimeters. And the reason why we choose to do that is because our data suggests that has the best results. Some of the sleeves we convert to sides and one anastomosis, but our preferred procedure to revise the sleeves if the patient wants a surgery is to a banded gastric bypass with 150 centimeters of a biliopancreatic limb. If the patient does not want a revision surgery and says that he wants some treatment for his weight regain, but no surgical intervention, as you know that we are doing a lot of these endoscopic procedures, and I do it myself. We do endoscopic sleeve reduction by overstitch device, just like Professor AlQahtani does, to treat sleeve weight regain. We do a lot of these for these gastric bypass at the gastric bypass outlet tightening with argon energy source, and also on one anastomosis. Plus, we have a very intensive medical intervention unit. We use a lot of GLP-1s and several other drugs which are available in India or across the world on the patient appeal process. Like we import a lot of phentermine and several other drugs to our country on the patient appeal process to treat the weight regain after bariatric surgery. So very exhaustive setup to treat revisions based on what sort of requirement, surgical, non-surgical, or lifestyle based.
And from our side, it's not different than Dr. Bhandari protocol, but in general, what we look for their current weight. If it is really suitable for surgical revision, meaning their weight maybe 20 kilos extra than their ideal body weight, they still have their comorbidity disease, so on, but we cannot revise somebody with 30 BMI, maybe recommend bypass or so. I will look for other tools. So it depends on the primary weight or the current weight they came with after their primary procedure. The second is their preference, because many patients will reject completely certain procedures, say, well, I will not go for that or this. The third is the problem associated with their revision. If there is reflux, there is stricture in their sleep, if there is some other problem, then that will dictate your path. And based on this information, you will tailor your approach. For somebody with major reflux and they still have a good weight, will go for bypass. Somebody with big, huge sleep, but they don't have reflux and they have good weight, will go for re-sleep. Somebody with little BMI, not much, and they are really not willing to go for other, and maybe their weight is not indicating to go for, maybe will go for medical or endoscopic, and so on. So we give the different option. It's a discussion with the patient, considering the facts about their history and the laboratory work and the radiology and endoscopy, and then we tailor the approach.
Okay, thank you, the three of you, for the sharing. And Professor Miguel, you there? Can you tell us about your experience, Miguel? Steiner.
Yes, I'm here. I have a question for Dr. AlQahtani. You show us interesting data about the same day procedures in sleeve gastrectomy. And I have a question. Do you apply in those patients a fast track protocol or free opioid anesthesia in this patient of same day?
Yes, we apply. Yes, we apply the ERAS and FAST protocol. However, we still use narcotics, and we use them maybe one dose before, and even we give them tramadol or tramal on discharge. And we give low dose, so if we discharge them in tramal 50 rather than 150 Q8 hourly, and we give them non-steroidal anti-inflammatory, maybe also other type of medications like Salbodine or others. So, but we do the surgery early morning. So the last case maybe will be midday, and they will stay until 11 and 11:30. And then we give them a bolus of folium before they leave, 1 liter bolus. And then we send them, and we contact them the next day at home. How are they doing? And they have 3 numbers to call, 24 hours access. If they have tachycardia or any fever or any problem. So in terms of hydration, we hydrate them well before they go, and we check them check on them the next day. They are still concerned about their intake, but they are not taking well. We'll bring them to the ambulatory service, and we give them again rehydration, check on their vitals in the next day, afternoon or in the evening. If they are doing well at home, they don't need to come back.
Thank you, Dr. AlQahtani. I think it's the right way to do it. And Dr. Bhandari, I have a question for you. You great lecture. You show us data on published the papers about our experience, about your experience in banded gastric bypass and in banded sleeve, and the data is there in the publications. But we are worried about the prosthesis, about the plastic prosthesis, the plastic band in these operations. I think remembering the gastric band. So what are your comments about this?
I think the adjustable gastric band and rings are two different concepts. The adjustable gastric band was probably, we used to have fluid-filled bands where you used to put the fluid and they used to impinge upon the esophagus. These rings are much smaller in size. They are pre-sterilized, prefabricated silicone-based rings. The erosion rate is not as high as those old adjustable gastric bands. So, and most of them here can be managed easily by endoscopy. So our experience is that this is an entirely different concept. I don't know why surgeons confuse it with the adjustable gastric bands, but this is a different concept. It's not like the adjustable bands.
Yes, it's a different physiology. I absolutely agree with you. Thank you.
Thank you very much, Anna, for your sharing, and thanks for the hot discussions, and you have all expressed your opinions. Now this session conclude. We will skip the break since we had a bit delay. Now let's start the next session. I will give the floor to Professor Zhong for host the next session. Yes, we are a bit tight in the timing, so I will give the floor to Professor Zhong Shai Hong as well as Professor Hu Xiao from Huaxi Hospital, and Professor Wu Yingxin and Zhang Jianchen from Hunan, as well as Bhandari, Professor Bhandari and Professor Miguel to host the surgery session. And also I will give floor to Professor Hu Sanyuan for demonstrating the surgery to us. Thank you. Hello, Professor Hu. Hello, President.
Yes, I think I understand the question. There are preliminary results. Is not Nissen, it's a Rossetti sleeve gastrectomy. The first one, the results are good on selected patients. I don't remember the right number, but 95% of the patients operated don't have a reflux at 1 year after intervention. In literature, the gastrectomy had 30% of gastric reflux after intervention. So these appear a good result. I think it's I don't know if this is the answer to fight against the reflux after the gastrectomy, but I think it's a route to do. This kind of operation. I don't work in this hospital from 2 years. I call with Professor Olmi monthly, and they perform I think 450 procedure. And I think in May, 26 May, I think there is a meeting speaking about this kind of procedure.
Next, I want to show you a video from Professor Yan for the revision surgery of male surgery, 49 years old. BMI is 44. Can you hear? Hello, Professor Zhu. Hello. Sleeve gastrectomy is a popular operation. And we need to pay attention to the venous, and we should start away 4 centimeters away from a pylorus, and also tract the greater omenters. We need to avoid bleeding in the process. Ultrasonic scalpels should be used for dissect and we need to have a proper dissect of a vessel around and greater omentum. T1, it's possible to have an anticoagulation issue, so we need to stop a hemorrhage properly, and then go up, get close to the gastric wall. We need to remove this part. And we need to dissect a greater curvature. There might be some adhesions. We need to separate them. Otherwise, when you dissect alongside the greater curvature, it's not possible to dissect them, separate them. And we need to properly process the adhesion in this area. Here, these are some vessels, and then in the lesser curvature, don't hurt those vessels. This is the posterior wall of the stomach. Then, going up, you will see this vasa bravia. So now we need to expose that completely to show vasa bravia. Especially when we reach the fundus of the stomach, we need to get close to the wall. Since the vessels here is short, we need to avoid damage. Avoid the damage of a spleen. So these are the adhesion in the posterior wall of stomach. Especially when it reaches the fundus of the stomach, especially for those high BMI, it's difficult to have a full exposure at this area. So it's very important to have the right exposure here. So these are the vessels in the posterior area. We need to avoid an incomplete coagulation. We put in a clamp here to avoid an hemorrhage. So now it reaches the vasa bravia. It's easy to hurt the spleen. Therefore, assistant when do the traction, forces should be placed evenly try to avoid hurting the spleen, causing bleed. So this is the vasa bravia. I also put in a hemorrhage and a clamp here. Here, we should be very cautious. We're really worried about an hemorrhage or hurting the spleen. It's difficult to stop bleeding. So that's also one of the reasons for conversion to open surgery. We need the right attraction, but not an excessive attraction, causing damaging of a spleen and hemorrhage. we get very close to gastric wall. We can dissect here.
Here, this is a place where we need to pay attention. This is a place where we have passed the vasa brevia. And this is the fundus. And we have to come to the left corner. And as you can see, there's some fat built up. Okay, this is the ligament. And this is the subdiaphragm vein. There's some vein here. And also, you put a scaffold here. And don't put it to the right, because this, you make sure that the device, though it's very tensile and very strong, does not protrude into everything. And we don't want the use of the stimulator to be affected. Then you come to the lesser curvature. Just 4 centimeters from the pylorus. And this is a very thick gastric wall. This is electrically driven, which is a stapler from Frankfurt Medical. And you stretch the anterior wall of the. You must look at the posterior gastric wall to see you have detached the adhesions, and this is the whole device is 8 millimeters big. And when you are cutting, you must check the posterior for every cutting. If there's any adhesion, if there's no adhesion, that's good news. And also stretch this open and for closure. Again, check the posterior gastric wall. So we have, this is another corner. We have used blue staples to make sure that you spare the liver or the spleen. You do not do any injury to these 2 organs. the whole greater curvature, and you use the line to make a continuous suture. And this is a normal procedure for greater curvature sealing to avoid leakage and avoid hemorrhage.
Can you tell us your preference of the color of the cartridge since the first one?
Okay. And we use this color because it's easier to find. If we use a white thread, as a contrast will be just terrible. Yeah, so purple is easy. So we use this color.
So the first one close to the pylorus, what color was?
This one is purple. This is the ball wire used in the first place.
Mm-hmm. And this suture, it is absorbable or non-absorbable?
It's absorbable, and the absorption is slow, and absorption can take several months. I think he said 6 months. And after suture, we check for any bleeding, and then we put it in a pouch, and then and also we put it out at the outlet to make sure that the gastric wall is not compromised. Actually, there was bacteria on the gastric wall. We want to make sure that the gastric wall surface bacteria does not affect the surface of the human flesh, and this is to protect the whole surface area, and to make sure the whole area of the skin does not get contaminated by the surface microbiota. So can you talk about the choker position? Where is the choker? We put a drain here. Generally, we put a drain tube here. Sometimes it's not in past. Actually, we observe closely, and so we have put in a drainage or drain tube, which will be extracted 2 days later. Can you hear me, Mr. Hu? Mr. Hu, can you hear me? Okay, so the whole procedure has come to an end for the sleeve gastrectomy, and we look at its morphology, and does not deflate, and that's good. So this is the whole video session. Thank you for your attention. Thank you, Professor Hu. And Professor Hu offered us a very beautiful and standardized procedure of SG, and I'd like to thank Professor Hu for setting up this whole platform where everyone can talk online globally. And we'll talk about communication. We are glad that in early November 2019, I was with Mr. Hu in Taiwan, and after that, COVID-19 hit us hard, and we could not physically see each other. we could not see each other or talk physically. I'm very happy that Mr. Hu for putting up this whole platform virtually. And actually, just like the former professors have talked about, now the SG or sleeve gastrostomy actually accounted for almost 60%. In China, it's at least the percentage of SG is at least 80%, with small variations across China centers. And in our center, it can account for almost 90% every year in Henan Provincial People's Hospital. And we have a small team in the bariatric surgery, and we have a small ward dedicated to bariatric surgery. We actually have 4 doctors doing this surgery, and we perform annually almost 200. It seems like because of all kind of reasons, because of publicity, or the patient to get to know that it has amazing hypoglycemic factor. So from January 1st till now, we have conducted 101 surgeries, and I feel that the volume has picked up, speed of increase. So back to the topic. For this part, Mr. Hu talked to us about how a standardized LSG looks like, and we believe that whether it was a city or the post-op leakage or obstruction, we need to consider very carefully. And also, we also consider the lasting efficacy and how we can reduce any regain of weight or WR. So we need to standardize the whole test, the whole LSG. So when we are mobilizing, we make sure that we can treat every blood vessel very carefully. We should cauterize more carefully, and actually, especially for the vasa, for the vasa previa, we need to be very careful. And people have different distance between the top and the bottom of the gastric area. So for different people, we need to make a case-by-case judgment. And actually abdominal chamber can be bigger for patients who are very big in stature, and we need to get the device bigger, right, and longer, and that leads to the compromised precision and even some bleeding. So according to our experience in the when it comes to vasa previa, because of the short device length or because of difficulty of the procedure, we will do one thing. That is, for those areas within the surgical reach, we will make a clean break, and then we will make the dissections in a good place. When the dissection comes to the proximal gastric part, the gastric and the influence of the exposure or the gastric exposure will be minimized. So then we come to the lesser curvature, where we do the last part of vascular mobilization, which will be easier and safer, and it will protect the blood vessel and the spleen, and that is a good way to achieve full mobilization. And of course, leakage can happen 6% in fundus, especially the esophageal gastric juncture, the S area. So we need to do a pouch or the margin control to make sure the leakage doesn't happen. That is the stress and the focus. And we have not a lot of experience. And we have, and I believe that for those of you who have a lot of experiences, I'd like to ask a question. That is, if you have done thousands of bariatric surgeries, as you know, these patients may become our long-term friends because they need to follow up regularly, and we need to pay attention to how they have changed their weight, they become fatter or thinner. So for the post-op patient management, do we have any experience? I'd like to ask all of you this question. Thank you, Mr. Hu. Any experience in post-op management? Can you hear me, Mr. Hu?
Can you hear me? Yes, I can. Thank you, Professor Hu, for excellent video sharing and explanation. Very smooth and standard operation. I have two questions for you. When you do reinforce, you did not restore the greater mesentery. So do you worry there might be some rotation after post-operative? I performed a sleeve gastrectomy in since 2006, and there's no reverse of a stomach so far. Sometimes some doctors believe that fixation is needed and to avoid a reverse. But in my case, I haven't seen any, so it's very low incidence. I did not fix it. So in the his angle, in the proximal of fundus and of stomach, some physicians would scalenize the fact together, and some surgeries have worried to hurt this area because the leakage, 90% of the leakage happens at the fundus area, so they leave a fat at that position. So what do you think? Yes, I'm also learning from others' experience. At the fundus, do not skeletonize the vessels too much, because we can prevent reflux at the his corner. So it's not necessary to remove too much fat in that area. So basically, my opinions is consistent with others. Thank you, Professor Hu. Thank you, Professor Li, for your question. Any other questions for Professor Hu's surgery? So whether stitches or whether to fix greater omentum, I think for those who fixed it, and they may have come across those reversion of a stomach. I came across one time. Whether to fix it or not, I think there's a very important conclusion. So in the pylorus area, there might be some vasa brevia. If the ligament is difficult to get to hold the lesser curvature, it may also revise. Generally speaking, I haven't fixed it. I do not stitch it. I do not do in reinforcement for the incisional margin. Basically, I stitches and no leak happened in my cases. If the staple lines is very neat and there's no need for stitches, because you may cause an edema and waste a lot of time. And there are also GEJ areas, and in most cases there's not necessary for stitching. I heard Professor Dong or Professor Wu in Suzhou Hospital. They had one case of fixation. So there must be someone who had come across this situation. That's why they emphasized the fixation of a greater omentum. 2 days ago, I saw live broadcast from Professor Wang. There was a performer at the pylorus ring, and so in those cases, it's possible that a reverse of a stomach may happen if it gets too close. This is Professor Ramos is still online. We have a very precious opportunities for everyone to discuss and learn from each other. Professor Hu, Professor Du, hello. Professor Liu Wenjing joined us in the discussion. Professor Wu,
I'd like to ask Professor Hu about how he used to deal with the situation of the patients with hiatal hernia and reflux. This is a contraindication in some cases for doing a sleeve gastrectomy. So position from him about recommendations of a sleeve in patients with reflux and hiatal hernia.
So for reflux patients, I just come across one case. We had a revision, an amendment. We did not fold. We basically will have a CT scan and a gastric and endoscopic check. And we check we just found there's one loosen in the fistula, so we did some amendment. Basically, there's very few, only one case.
I might answer some of this, but what we do in our practice, Almino, those who, it's not absolute contraindication, we discuss with the patient, the best option may be bypass, but if they say, is there a better or less invasive alternatives or some other option, because in our environment at least, and I don't know how is it in other region, people would like to go for sleep and they are preoccupied by having sleep. So they will discuss with you, can we avoid bypass? So we say, okay, we can repair the hiatus, we can do the sleeve, and we will see. If reflux continue, then you might require eventually bypass. If it resolves the problem, we'll do good. But the best option definitely is bypass if the patient is in agreement with that, but I will not consider it absolute contraindication.
In Professor Aayed, do you have any kind of experience with the association with the fund application in Nissen sleeve or Rossetti sleeve?
Yeah, we have done maybe around 20 cases in sleeve, where, and this happened in the discussion with the patient. Those who with severe reflux, that we know there is no major hiatus to explain their reflux. So it's mainly there is the muscle, the sphincters is weak. We offer them bypass and they will reject bypass. Can you offer us something with a sleeve? We said, okay, we'll do in sleeve. And we consent them on that protocol. And then we do it. I will do completely mobilization. being away from the stomach wall, not like the routine sleep. So not to have any thermal injury for the stomach or any traction injury. And then we leave and we create the wrap. It's very interesting because when we create the wrap, we create it after closing the hiatus. So we close the hiatus very well. We pass the tube, calibration tube, and we create the wrap. And then we do our division after creation of the wrap, not before. So we leave the wrap in place. We don't track. We leave it positioned very well, and we make sure our sleeve will take all redundant stomach, not damaging the wrap, and not leaving big pouch on the posterior wall of the stomach because you will not see it well. So you have to balance these things to create the wrap.
Okay. Amina, Professor Amina.
Professor Amina and Professor Wang.
I have a question for you. Amina.
Yes.
We all know up to now, more and more surgeons do OAGB, and like Middle East country and India, now the number of OAGB is more than RYGB. And I want to know, like you, with a lot of experience of RYGB, do you think the OAGB is good than RYGB? And you will change from RYGB to OAGB?
That's a good question, Professor CC1. I think that's a great debate. I continue most in favor of the Roux-en-Y gastric bypass. My preference continue the Roux-en-Y because I think that OAGB it's a bit more malabsorptive, so it is something in between Roux-en-Y and Sadie's procedure. So that's a good option for patients with bigger BMI and without reflux. If the patient presents some kind of reflux, I will continue to prefer Roux-en-Y gastric bypass. But what I can see is that the worldwide acceptance for one anastomosis gastric bypass, it is increasing. In some countries, it is replacing Roux-en-Y. So this is an interesting option. I think that the more options we have to treat obesity, the better. Depend on our preferences, depend on our experience. So for regular cases, patients with BMI 40, 45, I continue with the preference for Roux-en-Y. For patients with over 48, 49, 50 BMI, maybe one anastomosis is a good option. For patients more than this, Sadie's and duodenal switch, I think that we should look for the case, for the BMI of the case, for the severity of the metabolic comorbidities of the patient, for the presence of reflux, and these are good arguments in order to decide for one procedure or another. And you, are you doing one anastomosis gastric bypass?
I agree with you. Thank you. And Dr. Francesco, I have a question for you. Dr. Francesco.
Yes, good morning.
In your speech, I know in Italy, the 2019, the band operation is 6%, but 2020 increased to 9%. I want to know why, because in many countries, usually think the gastric banding, the long-term outcome and the complication, something. So why in Italy still gastric banding is increased?
Really, I don't know. If you see the number, 2020 is a year influenced by COVID, so the number could be not. You see the percentage 9% in 2020 and 76% in 2019. I don't know, in fact, because there are this high prevalence of gastric banding in Italy. Personally, I don't perform gastric banding only in well-selected cases because there are other choices to treat obesity. So, if the question why in Italy we perform 9% of gastric banding, the answer is I don't know.
Okay.
And here we have still a question from online. One is from Zheng to Fu. How do you do publicity for the center to perform the SG? And secondly, how do you manage the patients in your center? Thank you, Professor Zheng, for the question. And it's about, it's really something that is tricky for all the experts in the bariatric and metabolic surgery. And in the beginning part, we just did 20 cases in first year, then 50 annually, then 100. Now we do 200 per year. Why? We have the 5/11 on May 11th publicity day, and on that day, which is the obesity day, we try to tell people about the obesity issue. And this is, and also we have WeChat group chat to tell people about the upside and mainly downside of obesity, and for people to talk to each other. This is a good expansion of the knowledge education. And by also we have with kind of club. Also we have weight loss club, and mostly we believe we see patients who cannot lose weight even in the weight loss club, and we cannot persuade them to do surgery all the time. But it's a combination. Sometimes it's exercise plus surgery, etc. And these are kind of instructions can really increase the source of the patient introduction to our center. So in early days, we still need to do more publicity. Thank you. And also some audience asked question for Dr. Mohit, our Indian experts. And does India cover the insurance? Does India insurance cover the surgery? And do you think that the patient wants to do the bariatric surgery, or it's the bariatric surgery is done so much in India because of the good education in public or in the hospital? That's a question for our India friend, Professor Bhandari. Yeah, this question is for Bhandari. And I believe that actually India has more about 20 to 30,000 per annum for the India, and he has a hospital. Professor Bhandari has a private hospital and a lot of cases, and actually about 5,000 per annum for this specific hospital, and they have special reasons. Yes, they have good publicity, and also the obesity rate is high in India. So next time we can have a chance, we will invite Bhandari to tell us more about the facts of a lot of surgery being done in the India. So let's see if we have any questions. Also, I want to ask a question for Professor Hu, and I can see that from video. It's a very great video, do you still use the drain tube as a technical procedure? And also, chamber to chamber, it seems like you do a suture. Do you have a special reason for this? And so far, I put the drain tube as a normal part because I'm afraid there will be some sort of effusion. And I want to observe if there's any bleeding with the drain tube. And I use continuous suturing or anastomosis. So for the greater curvature, I use continuous suturing or anastomosis. So thank you. Yeah, you are very clear for. Do we have any question from you guys? If no more question, let's come to the closing part. Now let's invite the co-chair of this conference, Professor Almino Ramos, to do a closing speech. Let's welcome Almino.
Before my closing speech, I think that we have some minutes. Let me ask Professor Hu about the Plan B, because what we have discussing with surgeons all over the world, that really for patients with sleeve gastrectomy and insufficient weight loss or weight regain looks like, and I'm not considering reflux, just insufficient weight loss or weight regain, looks like conversion to Roux-en-Y gastric bypass, it is not a good idea. The results are not so better. So for Professor Hu, also you have a fail with the sleeve gastrectomy. Which one will be your Plan B?
Very quick question. Yeah, in China, SG is accounted for 95% of the bariatric surgery, and at least the other 5% are just the MIS. And why is that so high for SG in China? Because China has a high incidence rate of gastric cancer, so people chose the SG. And secondly, China's GERD, it's not so many like the Western. And in China, we don't have so many GERD patients. And actually, with internal medicine, people's with GERD can be well controlled. So anti-GERD surgery is not so many in China. So we don't see a lot of patients with GERD, so we chose SG. And if patients had a very obvious GERD, we do GB. And also in surgery, we do hernia repair in the intraoperative time. And we want to leave more, we also need to leave more room for the fundus. I'm not so sure if this gives you an answer.
Yes. I think we did a great meeting here, and was my pleasure and honor to join you in this meeting. Considering that this is our first meeting of FAMIS, Bariatric and Metabolic Club, I think we did it well. Let's thanks all the guys that join us here to listen for our discussions and presentations, for all the speakers, and I think quality of the presentations were really very good, and also thanks to FANG for this educational initiative. I think that is very important. We had the chance here to listen for different experience from different countries, from different regions, and to know how is bariatric surgery right now in these different places, about the vision for the future for the surgeons, about what will happen with bariatric and metabolic surgery. So was a great and this is a very nice meeting to take part. I hope we can have more meetings like this. We are open for your suggestions for new meetings, for new subjects, for new procedures to discuss, for new ideas. And I hope to continue working together with you in the next sessions. Thank you very much to join us and to share your experience with this group.
Thank you. Thank you, Alminos and everybody.
Thank you. Thank you, everybody.
Thank you.
I'd like to thank Professor Almino for the speech. And we know that Almino is a close friend to China's bariatric surgery, and he has visited a lot of hospitals. And when he is still the IFSO president, he has visited a lot of countries. And Almino is a guy who is very professional in his work, and he has visited a lot of places. He's well known. He's amazing. And now, last but not least, let's invite the chairman of the FAMIS Bariatric and Metabolic Club to deliver a speech. Okay, everybody, dear friends, and it's a very successful meeting we have seen, and we have achieved the effect of this whole conference. And so other countries, right, Spain, Italy, India, Brazil, and Saudi Arabia and China have all talked about the experience, very good lessons, very experience. And we have achieved a common goal, which is to educate and to be educated and to learn. And actually, we believe that sleep is still the dominant procedure for treating the obesity. And GB is a southern line. And well, in Latin America, it's a different story. Yeah. So it's about cultural, and GB is more prevalent in Latin America. And we believe that new technology will appear. And also in India, after the resection, they have a valve addition, which is something worth discussing. That's interesting, and that is his opinion. And also, we have seen an increase of OAGB. Yeah, the OAGB. These are new procedures. We also see the ESG, which is endoscopic or endoluminal. And I believe that these new procedures are very thought-provoking procedures. And we also hope that all these bariatric surgeons can set up a database for future researches and for future evaluations of the efficacy, and for us to know the future. Yeah, and we can see that in Middle East, especially in Saudi Arabia, they have a new concepts and practices in bariatric surgery, which is what I'm learning from. And for instance, ERAS, which is a regular concept, and for ERAS, and 97% of patients get discharged within just 2 or 3 days, which can really avoid the loss, the wastage of medical resources. And also for those with BMI over 45, the medical insurance was not included, because in a lot of China's places, the bariatric surgery was not included in the medical insurance, but for some places, it's a different story. We have been included in the medical insurance. Actually, those patients with metabolic dysfunctions have can do just this kind of bariatric surgery for free with medical insurance. And so we have to do a lot of public education as well as publicity or awareness raising programs. This is a good setting, and I'd like to say this is a good meeting. I'd like to thank everybody, the moderators, the panelists, and the keynote speakers. And also like to thank thank Franco for providing such a great platform. I look forward to the future where we can hold another meeting in the second half of 2021 this year, and we may reach out to more regions, okay, of the world. And hopefully in that second meeting of the club, we will have more things. Thank you very much. Let's give the floor to Mr. Zhong Minghuai, who is the executive president. So today, I'd like to thank everybody for taking time out and to attend this meeting. So, yeah, we have to make a call for papers. Do you have the slides for making a call for paper? So I don't have it. I can send it to you. Right. There's a magazine. It's the Frontier of Physiology, which invites us to write papers. The impact factor is 3.6.
We hope global experts can share your experience and publish a paper in the magazine. So after this meeting, we will send you by email if you are interested in the magazine publication. You're welcome to send your paper or documents to us. Thank you, Professor Hu. Thank you, all the professors, experts. Professor Wan, we conclude here, okay? Yeah, okay, good night, and